This content is AI generated for informational purposes only and should not be directly used for clinical decision-making.
Hello and welcome back to the Neurosurgery Hub podcast. I'm Dr. Aris, a senior attending in neurosurgery.
And I'm Dr. Alara, a research fellow. Today we're looking at a fascinating new study from BMJ Open, published in 2026, titled Comparison of the Predictive Value of APACHE II, SOFA, SAPS II, GCS, and GCS-P scores for in-hospital mortality in critically ill patients after craniotomy, a retrospective cohort study in a Chinese tertiary hospital.
This is a topic that hits home for anyone who spends time in the neuro ICU. We all know the pressure of those first 24 to 48 hours after a major craniotomy. Patients often require the ICU because of elevated intracranial pressure, impaired consciousness, or respiratory failure.
Exactly, Dr. Aris. And the study points out that these conditions place a significant demand on medical resources. The goal here was to see which of our standard scoring systems actually gives us the best crystal ball for in-hospital mortality. They looked at 5 different systems: APACHE II, SAPS II, SOFA, and then the more neurocentric GCS and GCS-P.
It's an impressive undertaking. This was a single-center retrospective study out of Beijing Taitian Hospital, which is a massive teaching center. They screened over 1,700 patients across 3 ICU wards. That's a robust sample size for this kind of analysis.
It really is. To be precise, they included 1,717 adult patients who underwent craniotomy and stayed in the ICU for more than 24 hours. They were very specific, excluding pregnant or lactating women and those in other clinical studies to keep the data clean.
Now, before we get into the results, let's quickly refresh the listeners on the GCS-P, because it's a relatively newer tool compared to the classic GCS.
Right. In 2018, Brennan and colleagues combined the traditional Glasgow Coma Scale with the pupillary light reflex to create the GCS-P. The idea was to enhance the predictive power of the GCS, especially for outcomes in traumatic brain injury and other neurocritical conditions. This study wanted to see if that extra pupillary data made a difference in post-craniotomy patients.
And they compared it against the heavy hitters of the general ICU, APACHE II, SAPS II, and SOFA. These scores are meant to be comprehensive, looking at sepsis, liver dysfunction, and kidney dysfunction, things the GCS obviously ignores. So, Alara, what did the data show?
The overall in-hospital mortality rate for this cohort was 6.8%. When they ran the ROC curves to assess predictive accuracy, SAPS II and APACHE II came out on top. SAPS II had an area under the curve, or AUC, of 0.822, and APACHE II was right behind it at 0.819.
So the more comprehensive physiological scores were the most accurate. But how did our bedside neuro exams hold up?
Surprisingly well, actually. GCS-P had an AUC of 0.812, and the standard GCS had 0.803. Statistically, there was no significant difference among SAPS II, APACHE II, GCS, and GCS-P.
That's a vital point for the residents listening. Even though GCS and GCS-P are much simpler and don't account for things like creatinine or heart rate, they were nearly as effective as the more complex SAPS II and APACHE II for predicting mortality in this specific surgical population.
However, there was one outlier, the SOFA score. It had the lowest predictive accuracy with an AUC of 0.762. Both SAPS II and APACHE II significantly outperformed SOFA.
That is interesting. SOFA is widely used for sepsis and general organ failure, but perhaps it's less sensitive to the specific nuances of a post-craniotomy patient. But I noticed the paper dives deeper into subgroup analyses. In neurosurgery, the pathology and the location of the lesion change everything. Did the scores behave differently for, say, a supratentorial tumor versus a posterior fossa case?
They did. And this is where the study gets really useful for clinical practice. For patients with supratentorial lesions, APACHE II, SAPS II, GCS, and GCS-P all showed similar predictive accuracy, and they were all superior to SOFA.
Which makes sense. But what about the infratentorial lesions? Those posterior fossa cases can be much more volatile.
That was a surprising twist in the data. For infratentorial lesions, SOFA actually outperformed GCS and GCS-P.
Now, that is a nuance worth discussing. Why would SOFA be more predictive in the posterior fossa?
The authors didn't speculate extensively, but it might suggest that in those cases, systemic physiological stability and organ function, which SOFA tracks, might be more indicative of the overall trajectory than just the motor or verbal response captured by GCS.
It's a good reminder that we can't rely on a single score for every patient. what about the disease type? Did they look at vascular cases versus tumors?
Yes. Among patients with cerebral vascular diseases, SOFA again had the lowest predictive accuracy. But here's the win for the newer GCS-P score. In the cerebral vascular group, GCS-P significantly outperformed the standard GCS.
That's a strong argument for incorporating the pupillary reflex into our routine scoring for stroke or aneurysm patients. It adds that extra layer of prognostic value without needing a lab draw or a complex calculator.
Exactly. The study authors emphasized that accurate prognostic prediction can facilitate stratified patient management and optimize the allocation of medical resources. If we can identify the high-risk patients early using these scores, we can manage them more aggressively.
Let's talk about the strengths of this study. I noticed they did an a priori power analysis.
Yes, they set the power at 0.9 and alpha at 0.05 to determine the sample size, which ensures the results are statistically robust. They also used the Uden index to establish optimal cutoff values, which really improves the clinical utility of these scoring systems. Instead of just saying a score is high, they provide a threshold that correlates with mortality risk.
They also collected a very comprehensive list of variables: surgical characteristics, lesion localization, complications. It helps mitigate those confounding factors that often plague retrospective studies. But, of course, no study is perfect. What are the limitations we should keep in mind?
The primary limitation is the retrospective design. That always brings in the risk of selection bias and unmeasured confounders. Also, it's a single-center study in a Chinese tertiary hospital. While the sample size is large, we have to wonder if these results translate exactly the same way to a smaller community hospital or a different healthcare system.
Right. And they specifically looked at patients in the ICU for more than 24 hours. So for those fast-track craniotomies where the patient is in and out of the unit in 18 hours, these findings might not apply.
True. But for our critically ill population, the ones we're most worried about, the message is clear. APACHE II and SAPS II are the gold standards for accuracy, but GCS and GCS-P are incredibly close seconds.
It's quite reassuring that the tools we use at the bedside every single hour, the GCS and the pupils, carry almost as much weight as the complex systems that take 30 minutes to calculate. It reinforces the value of the neurological exam.
Exactly. And for the residents listening, remember that SOFA might not be your best friend in the neuro ICU, especially for supratentorial or vascular cases, but don't discount it if you're dealing with a posterior fossa lesion.
Great summary, Alara. To wrap up, the study concludes that while APACHE II and SAPS II are excellent, GCS and GCS-P are comparable and highly effective for predicting in-hospital mortality in post-craniotomy patients. SOFA, however, appears less effective in this specific cohort.
It's a call for us to be more precise in how we use these scores to guide our clinical decisions and communicate with families.
Well, that's all the time we have for today. Thank you for joining us on the Neurosurgery Hub podcast. I'm Dr. Aris.
And I'm Dr. Alara. We'll link the full BMJ Open paper in the show notes. Until next time.